Thank you all for your attention. I do not apologize for the technical difficulties. So I'm going to talk about obstructive lung disease today. These lectures will build on the PFT lectures that I gave last week, and then you'll get one on restrictive lung disease and pulmonary vascular disease following that. So this lecture, I'll review lung mechanics and in particular, what goes on in acute exacerbation of obstructive lung disease. Talk about asthma and COPD, and then some of the less common diseases of obstruction that you need to keep on your differential when you're thinking about airway obstruction, in particular, small airway disease and bronchiectasis. Cystic fibrosis, hopefully they have a diagnosis by the time they make it to you if they see you in clinic or an inpatient. Occasionally some phenotypes of cystic fibrosis are diagnosed later in life though. So ventilatory obstruction is a problem with airways, and in particular it's a problem during exhalation, air getting out. So looking at this diagram here, and this is a COPD asthma model. The normal airway has a nice, smooth, muscular wall here, no hypertrophy, no extra secretions. And when there's airway inflammation, you get hypertrophy of the muscles in the airway, difficulty clearing secretions because of limited flow, and inflammation sets in. And the inflammation exacerbates the problem, causing bronchospasm, more inflammatory cell recruitment, and more problems with obstruction. Looking at it on the trichrome slide here, you can see a patient with asthma has hypertrophied muscle in the bronchial wall here, and really hypertrophied glands with mucus secretion here. Also a thickened basement membrane. So this is a pretty abnormal bronchial here, and the function in terms of its ability to relax the muscle and stay open is impaired, as well as the airflow in this narrowed lumen you can see compared to the normal. The expiratory flow curve here, when you get PFTs on patients with obstructive lung disease, will show a decreased FEV1, meaning that at 1 second, the patient's ability to exhale is less than the predicted. So the predicted for folks for FEV1 and FVC is based on gender, age, and height. And to diagnose obstructive lung disease, FVC is normal or decreased, FEV1 is decreased, and so the ratio is less than 70%. And that's what's going to show up on all your tests and everything. The shape of the curve here is a scalloped shape, and the red dots here is the normal expiratory flow curve. And you can see that at different lung volumes, you have much less flow in liters per second. Categorizing these is mild, moderate, severe, and very severe, and it's based on the percent of predicted FEV1. Don't make the mistake of looking at the ratio and trying to categorize, because that's easily done when it's less than 70%. So determination of flow, to review last lecture, is based on the difference in the pressure from the alveolus to the airway opening, the mouth, and the resistance. So this is your flow here. And so if there's a higher resistance situation, flow is decreased. And in obstructive lung disease, that's exactly what you have. You have a higher resistance system because the lumen is narrower and there are often secretions obstructing the airway. So it's much more difficult to exhale despite more effort in generating a higher pressure. So the flow limitation is due to increased airway resistance. And looking back at this slide, you can have increased resistance at really any lung volume where this represents the larger airways, this the medium-sized airways, and this the small. And so this obstructive curve, as an example, shows obstruction at all lung volumes, though there can be differences where you have normal flow up to here and then obstruction develop at the smaller airways. We'll talk about that later. And the review of the units here, this airway resistance is airway's diameter, any obstruction, or any fixed obstruction like masses. So as I said before, you can see it on the slides, secretions, bronchospasm, and then the airway's diameter are what's causing flow limitation in obstructive lung disease. And what that causes, especially at higher respiratory rates, is air trapping. If patients with obstructive lung disease have any increase in their respiratory rate and need for a higher minute ventilation, they're often unable to fully exhale before the next breath is taken. And that's a very uncomfortable feeling, causes anxiety, distress, and drives a faster respiratory rate. So folks with asthma exacerbation that are unable to exhale, and these are ventilator flow curves, but this is also an example of what happens to patients that are having an asthma attack outside the hospital, is their expiratory flow is not gone back to zero, and this area, yellow here, represents air trapping. So over time, the lung volume goes up and up and up with each breath. And when you have an increase in intrathoracic pressure from air trapping, it does a few things. It makes it much more harder to inspire the next breath because the intrathoracic pressure is already very high, so it's harder to generate that negative pressure that you need to take a breath. And when the lungs become hyperexpanded, especially if patients are hypovolemic, they can actually become hypotensive from the air trapping in the chest, compressing the mediastinum and great vessels. So folks with asthma attacks, COPD exacerbation, that are air trapping can become very distressed very quickly and are actually hard to ventilate with non-invasive ventilation because the pressures needed are very high. So the point of control of asthma COPD is keeping this kind of physiology from happening. In addition to having the increase in thoracic pressure and this decreased pressure gradient, that does result in smaller tidal volumes, which results in an increase in the dead space fraction. So the breaths become less efficient and the patients have more problems oxygenating and in particular excreting carbon dioxide by having a minute ventilation. Also, the diaphragm becomes weaker as air trapping occurs because the diaphragm flattens. They're not able to get that contraction that draws the breath into the chest. If the diaphragm starts here, the mechanics are poor, you can't generate that delta pressure. And then finally, the sensation of dyspnea really drives tachypnea. And all caps, a vicious cycle of flow limitation. So to summarize that part of the talk, obstructive lung disease in general is a flow limiting pathologic change. Diagnostic criteria on spirometry is the FEV1 to FEV ratio less than 70%. And air trapping is a primary driver of respiratory failure in obstructive lung disease. Any questions about that part? That was my study friend when I was a resident.
Helpful?
No. So asthma is kind of the hallmark obstructive lung disease that you'll see in your clinic along with its friend COPD. And it's extremely prevalent disease. And asthma itself, as a descriptor of obstructive lung disease with bronchodilator reversibility, is a huge umbrella. really what we call asthma is a lot of different phenotypes that may actually be individual disease states if you want to get down to it, because some of them are eosinophilic related, some of them are mast cell related, many phenotypes, and there's a lot of ongoing research into separating these asthma phenotypes so we can treat them better. And one of the more recent medicines to come out is the anti-IgE, what is it, becalizumab or something like that? Something like that. And it's actually for people with a hypereosinophilic asthma phenotype, does a great job of reducing symptoms, hospital admissions, etc. But for folks with a really allergic mast cell-based phenotype, that drug does nothing. So asthma is really genetic, environment, and developmental, like most medical disease, susceptibility, and then environment. You'll often see environmental factors contribute to asthma in areas of high pollution, areas with poor housing. You know, one of the main triggers for a lot of children for asthma is dust mites and cockroaches in the house. Those allergens are really irritating to the airways and can cause poorly controlled asthma in somebody that would otherwise not really have asthma symptoms at all. And starting early in life with asthma, you start that cycle of inflammation and exacerbation that really causes remodeling of the airways and kind of fixes the asthma phenotype into adulthood. Diagnosis of asthma is largely done by history and physical. I mean, people have the classic I can't breathe and I wheeze when I exercise, or they have triggers of asthma that are known to the patient. Dust allergens, exercise, and cold air are the main ones that you'll hear when you take your history. Other triggers, viral infections are really a pretty common cause of asthma exacerbations requiring hospitalization. In children, respiratory syncytial virus, and in adults, viruses like human metapneumovirus. Some of the ones that don't really cause the classic flu syndrome, like influenza and COVID, it's more the non-COVID coronaviruses, which will come back one day and cause asthma exacerbations. But for now, this is helping us out. Symptoms, cough, and especially night cough, is really the most common symptom of patients with asthma. Not all of them perceive their dyspnea or their symptoms as a wheeze. Chest tightness is often a common complaint as well. So there's a questionnaire, if you need it, to help pin down the diagnosis of asthma that includes the number of days they have symptoms, what the symptoms are, and then how often they have to use bronchodilators to categorize how well controlled the asthma is, and cough is included in that. When you get spirometry on somebody with asthma, you see the obstructive curve here, and you see that those flows improve with a bronchodilator. And this bronchodilator response, to be diagnostic, is a 12% increase in FEV1 from their baseline and a greater than 200 mil overall increase. And you can see the clinical classification here: symptom frequency, nighttime symptoms, percent of predicted FEV1, short-acting bronchodilator use, and mild persistent, moderate persistent, severe persistent. And for categorizing these folks, the severe persistent ones certainly need pulmonology referral, and moderate persistent, if you use your step-up therapy, which I'll talk about in the next slide, and they need more than one step up in consecutive clinic visits, that's also a reason to refer to pulmonology, because you may need to dig a little bit deeper into this and give the patient more tailored therapy for asthma. So environmental control is one of the very important cornerstones of asthma management, but also medications to manage symptoms. And depending on the patient's asthma severity, a short-acting beta agonist, albuterol, as needed, is really the starting point. And if somebody has asthma that has clear triggers, exercise or cold, then they can pre-medicate to avoid having symptoms of asthma. So many athletes will hit the albuterol before they go out and do their athletics so they don't have an asthma attack while they're trying to score baskets or goals. I know people like soccer here, like this guy. They score goals, not baskets.
And now with the newest,
Who said football?
now with the newest Gina, like the low dose ICS and LABA PRN can be done instead of PRN albuterol.
Exactly. Yeah. Yeah, this slide I think is 5 years old, and so the newer guidelines come out. Maybe I should update it someday. So your step-up therapy here starts with a low-dose inhaled corticosteroid, and if the patient is still having persistent symptoms, step up to medium-dose steroid or add a long-acting beta agonist. And then as you get to step 4, 5, 6, this is where you get into pulmonology referral. You may need medications that affect mast cells or medications that affect IgE. And an important thing to think about here is, asthma is a seasonal disease. It is triggered by environment. So if the patient's able to improve their environmental triggers or their symptoms get better, remember to step down these asthma medications if possible. If it's well controlled for at least 3 months, you can go back, peel some medications off, because as you know, doing primary care clinic, polypharmacy is a huge problem. And though asthma itself is a pretty small contributor to that, it's always good to be mindful of how many medications your patient's taking, because the more medications, the more noncompliance. And always want to step that down. So, when they lose weight and start eating right, you can take those antihypertensives and hypoglycemic medicines away, right?
I have a question, actually. I know they removed the black box about the LABA alone in general and asthma. It's not true that they increase mortality, but still people don't use them. Is there anything about removing ICS, just like COPD, where like any inhaled ICS, it causes more pneumonias, whatnot, and
not for asthma.
Not for asthma.
So the acute inflammatory part of what produces the asthma phenotype is really steroid responsive, where for COPD, it's less clear that that's helpful. And also the COPD phenotype is marked by even more abnormalities in how the bronchial and alveolar cells work. And steroids actually can cause or really increase the risk of pneumonia because of how those cells are altered. There's tissue destruction in COPD, where in asthma, there's inflammation, there's bronchospasm, but the cells and mucociliary clearance is not as compromised.
Okay.
Yeah, so the steroids are actually...
The pathophysiology.
Yeah, the steroids are net helping, where in COPD, it's not clear that they really do anything and can cause harm. Though they still are prescribed, I mean,
But they change it to LABA-LAMA now.
Yeah.
Leave steroids unless they have eosinophilia.
Yeah. Asthma exacerbations are life-threatening. So you will see people admitted to the ICU during your residency with asthma exacerbation. And you'll also see patients in your clinic or in the ER with different levels of exacerbation. So it's important to keep in mind the clinical signs, and then, if patients are admitted, the measurements that are associated with asthma exacerbation and what to do. So a moderate asthma exacerbation here is a patient that has worsening symptoms. They say, I can't quite catch my breath, coughing a lot, and my chest feels tight, and it's not getting better with my bronchodilators. This might be somebody you see in clinic. you can check a peak flow. Most patients with asthma have a peak flow meter at home. And do you have a spirometry in your medicine office for flow? Yeah. So you can have them just do a peak flow, and they should know what their predicted best is. If you have a peak flow reduction and worsening symptoms, moderate asthma exacerbation, this is somebody that you can increase their medication, probably start oral steroids to decrease the inflammation rapidly, follow up in a week.
And that's outpatient management.
That's outpatient management, yep. These folks rarely come into the ER, especially if they're chronic asthma, because they know what their symptoms feel like and when they get out of control. If you were to get an ABG on somebody with these moderate symptoms, you may actually see a respiratory alkalosis from tachypnea. So they're still, their obstruction is not so bad that they're air trapping at this point. And they're tachypnic because they feel short of breath and they're working harder to breathe. And you'll actually see hyperoxemia because of the increased minute ventilation. Now, acute severe is somebody that looks distressed when they come in. And you may see this in your office too. And this is when you give your firm colleagues a call and say, I got one for you. And you know, when you get that call from clinic, it's never good. I'd rather take an ER. I'd rather take an ER patient than a direct admit from clinic, but that's how it goes. So these patients look distressed, tachycardic, tachypnic. If you measure their peak flow, it's very reduced, and they can't really talk in complete sentences. And this is your classic normal ABG, but acute severe asthma exacerbation that everybody asks you on the quizzes, and they want you to say, oh, the ABG is good, they're okay. Don't say that. As the acute severe progresses to life-threatening, this is when you get the very severe air trapping and all of the physiologic changes that go along with it, in particular hypotension. I hope you don't see cyanosis. You're really far gone at that point. And also poor air movement in the chest on exam. This is your impending failure right here. And this is your should have intubated them 3 hours ago blood gas. So this is a progression of asthma symptoms. And, you know, there is a complete spectrum that will take you all the way from clinic to the ICU. And the point is to get them here, start steroids, schedule bronchodilators as an outpatient, and have close follow-up in the clinic to make sure that they don't get here. So COPD, like asthma, is also a spectrum of pathophysiology. And I really like this illustration because it's all you need to know about COPD. You just look at the patient and you know what their phenotype is. There obviously are mixed chronic bronchitis and emphysema phenotypes, but really thinking about somebody with COPD exacerbations, a lot of sputum production, frequent infections, versus the skinny dude that's worked hard to breathe for 20 years and is really more of an air trapper than inflammation and chronic pneumonia. Most fall in between these pink puffer and blue bloater phenotypes. Once again, very common prevalent disease, and cigarette smoking is the primary cause. So, you know, unlike asthma, this is a disease of substance abuse, basically. And this is why we counsel everybody to quit smoking. And, you know, cigarette smoking prevalence has decreased in the last few years, fortunately. So hopefully down the road, when you guys are in the middle of your careers, you'll see less COPD from cigarette smoking. And looking at the, these are H&E slides here. You have your normal lung, and then emphysematous lung here. Oh no, this is your emphysematous lung, this is your normal. These labels are applying to this drawing here. So emphysematous lung, you see there's a lot of loss of alveolar units here. There's even loss of vasculature. So when you have advanced emphysematous change, there's actually less surface area of the lung to work with, So breathing in COPD is less efficient for that reason. So you can see in the normal lung here, there's good vasculature throughout, and you can see your alveolar network is more coherent. This is actually a little bronchiole here that they've got on the edge that you can see that big gap. Here, similar to asthma, you'll have hypertrophy, inflammation, mucus plugging here. This is a cross-section of a bronchiole. And at a higher magnification here, you see an increase in the goblet cells and mucus secretion, inflammatory infiltrates. You can see neutrophils here. And this diagram here is kind of looking at the emphysematous alveolar unit versus the normal. And this H&E slide up here really illustrates that difference, where you'll have, you know, compressed small airways and less surface area. So once again, history and spirometry are how you diagnose COPD. It has similar obstruction to asthma, though you don't often have bronchodilator reversibility. If you get full PFTs, you may see an increased total lung capacity from chronic air trapping. And also imaging can be really helpful in COPD because you can see the classic barrel chest here. You know, when it gets to this point, you've probably made the diagnosis, but also COPD is comorbid with a lot of interstitial lung disease, especially in patients over 50, and also comorbid with lung cancer. So these are patients that you're going to want to have a CT scan of the chest to do cancer surveillance. There's good data for that started about 10 years ago. Hopefully you all are doing that in your clinic for your smokers. And also to look for ILD or any areas of chronic inflammation. COPD severity is gold still, and that's based on the percent of FEV1 predicted. And very severe here. These folks often have chronic respiratory failure. If they're a pink puffer phenotype, it's usually a compensated respiratory acidosis from air trapping. If they're a blue bloater phenotype, it's usually chronic hypoxemic respiratory failure from inflammatory lung infiltrate, shunting, destruction of alveolar units. And so cornerstones of COPD management, number one is smoking cessation. If your patient's still smoking, it almost doesn't matter what else you do. You're not going to keep them out of the hospital when they have severe COPD. So that's number one. And then medication management here is very much like asthma, based on the severity of the disease. You step up to short-acting bronchodilator, adding treatment with long-acting bronchodilators. Corner cases can still be responsive to inhaled corticosteroids. And if they have repeated exacerbations, you can consider steroid bursts or long-term steroids for suppression. If you get to this point, they should be seeing a pulmonologist. And when chronic respiratory failure ensues, the patient's usually chronic oxygen, often at night. And then there are some surgical treatments for severe emphysema, bullous lung disease. You know, before I talked about the change in the respiratory mechanics with diaphragmatic flattening. This becomes a fixed feature of people with COPD and air trapping, and sometimes lung volume reduction surgery can really improve the patient's oxygenation and ventilation. Anything else I want to say about that? Notice that there's no step down here like there is in asthma, because this isn't a reversible disease. This is a fixed progressive disease. Once you have a COPD diagnosis, your FEV1, well, everybody's FEV1 goes down after you turn 30. So good luck to all of you. But it's going to be a progressive disease where they're already starting with lung injury, and you're going to get an FEV1 slowly decrease over time. So there's no step down unless you get a lung transplant, which, you know, some folks with severe COPD that are otherwise very healthy, haven't smoked for years, are good candidates for lung transplant.
before we move on, so like we touched base with the mortality benefit. Obviously, if they're smokers and if they're hypoxic, these are at least on the boards are the two main things that would reduce mortality. But I know like there was like I think last year there was a secondary analysis of the impact trial that showed mortality reduction in people who have bad enough COPD with FEV1 less than 50% and a history of hospitalization, and they randomized them to. That was a secondary analysis, but the initial trial randomized people to triple therapy and one inhaler versus dual therapy, and the people on the triple therapy actually had mortality benefit, but I don't think that will be in the exams at all, but just something that you should know at this point. That was the first trial or the first analysis of a trial that ever showed mortality benefit in COPD.
Because usually the outcomes for COPD are surrogate markers like 6-minute walks, symptoms, questionnaires, reduction in admissions, reduction in ER visits. You know, I think that the triple therapy for people with severe COPD is certainly indicated, though I would say more trials are necessary before you can hang your hat on a mortality reduction, because really the nature of COPD is that you will die from it eventually unless something else gets you. And a lot of folks, because of comorbid conditions, usually die of cardiovascular disease or PE, DVT before the COPD gets them.
And then the lung reduction surgeries, also they're indicated with bad FEV1s, but not very bad. Usually if they're, I think less than 20% of FEV1, then they're usually not a candidate for lung reduction surgeries. But if they're sick enough and their FEV1 is higher than 20, then it's indicated too.
And they have to have a distribution of emphysema amenable to it. I mean, the classic for lung volume reduction surgery and classic COPD is apical is your most involved area of emphysema. And so they can take the upper lobes out and the lungs fill up the whole chest still, but you have better mechanics. So the chronic respiratory failure you see with COPD is a normal pH, elevated PCO2, and elevated bicarb. So compensated respiratory acidosis. Whether there's hypoxemia or not is dependent on the COPD phenotype. Folks with more inflammation and sputum production tend to be hypoxemic and have chronic hypoxemic respiratory failure, or patients with very advanced emphysema with late stage GOLD 4, and you'll actually see the DLCO extremely reduced in these patients because their alveolar surface area is so compromised. If you have a really severe COPD phenotype, even in a smoker that's younger than 50 years old, keep in mind alpha-1 antitrypsin disease. It's a real easy test to send. It's high sensitivity and specificity titer, and these folks often have a basilar predominance of the emphysema, which can be a clue that this isn't necessarily your regular tobacco-related COPD. And folks with alpha-1 antitrypsin that are smokers will often develop pretty severe obstructive lung disease in their 30s, and people will say asthma, 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 asthma. Quit smoking, quit smoking, quit smoking. I don't want to quit smoking, I got asthma. And then somebody finally gets imaging when they are admitted, and it's like, wow, these lungs look bad. So young patients with very severe symptoms that are smokers and don't have a clear asthma history, most folks with asthma are diagnosed in childhood or their early adulthood. If it's a new onset problem, just keep that in a differential. And this likes to show up on tests a lot too. So moving on from asthma to COPD, small airway disease or bronchiolitis has similar symptoms to COPD and asthma, but really is reflective of bronchus constriction at these very small airway levels at the respiratory bronchial level here. And patients can have pretty severe sensations of dyspnea and exercise intolerance, but have relatively normal spirometry if they have small airway disease or bronchiolitis. And the causes of this are twofold. Vasculitis is a very common cause of bronchiolitis. small and medium vessel vasculitis. And that's often a really hard diagnosis to make in an isolated setting here. But if patients have a vasculitic syndrome with other manifestations, Scherg-Strauss being a classic one, then the diagnosis becomes easier. Also, exposure to environmental toxins is a pretty common cause of small airway disease. A really big cohort of folks with small airway disease was the first Gulf War. United States soldiers in the 90s were exposed to burning trash pits and came back with shortness of breath and not feeling right. Normal spirometry took a while to make that diagnosis and that connection with the trash pits. The lesson wasn't learned because the 2003 Iraq and Afghanistan wars that have finally shut down now, #political statement, have actually resulted in this same phenotype, unfortunately, because of the environmental exposures that the soldiers had. Not only the burning garbage, but the dust and explosions and everything. So moral of the story, don't go to war, you'll get small airway disease.
That's why you should have.
Hey, it's pulmonologist speaking there, right? So other causes of bronchiolitis, post-infectious, people have the lingering shortness of breath and cough for months after these respiratory virus infections. And a lot of times if you do spirometry, you'll see the airway obstruction in the FEF, 75% small airways. And this gets better over time because the airways heal. Toxin-induced, as I said before, connective tissue disease, and then chronic rejection of a transplanted lung is another cause of bronchiolitis. Summary of that part. So asthma is characterized by a reversible inflammatory airway obstruction. COPD is progressive and irreversible. And keep in mind on your differential in patients with normal spirometry, but a history that really says asthma or obstructive lung disease, that these other causes are worth looking into. Any questions about that part? All right. So bronchiectasis is a syndrome of permanent dilatation of the airways. And it is a condition that's just a descriptor of the dilated airways. There are many causes of bronchiectasis, from congenital causes to recurrent aspiration events and injury to the airways, to diseases like cystic fibrosis, which are problems with mucociliary clearance. But what bronchiectasis phenotypes have in common is that it's very difficult to expectorate mucus in these bronchiectatic airways because they actually have destruction of the airway wall and loss of muscular function. So the cough is ineffective, the ciliary clearance is ineffective, and you end up with permanent mucus plugging that's very hard to get out with normal respiratory effort. And they have a very classic, I guess this is like a latte with oat milk, not a triple shot though. Yeah. And they have a very classic pus, liquid, and foam layer to their sputum with the bronchiectasis. It smells really bad. There's often Pseudomonas in there. And the hallmark symptomatically is recurrent pulmonary infection. So you suspect bronchiectasis in somebody that comes in, let's say a little old lady comes in, she gets pneumonia 4 times a year. She's a non-smoker. She's skinny, doesn't look great, and has nasty cough, gets better with antibiotics. This is a phenotype, somebody that you'd think about bronchiectasis, and a chest x-ray is a fair way to diagnose bronchiectasis in advanced disease. Chest CT gives you better look at the architecture. So this is what it looks like. This is unilateral focal bronchiectasis here. This is probably either a congenital problem or somebody that had a very severe pneumonia or acute lung injury that resulted in this permanent bronchiectasis. This person here looks like they have an interstitial lung disease and traction bronchiectasis. And you can see, this isn't a great view from the slides and how far you guys are away, but you can see tracks of dilated airways on this slide here. And like everything I talk about, this is a vicious cycle of disease. You know, it develops due to inability to clear secretions, and then that chronic inflammation worsens the injury to the airways, etc. So if it starts earlier in life, it's going to be cystic fibrosis, ciliary dysfunction, or immunodeficiency that lead to ciliary dysfunction or just inability to respond to inflammation appropriately and clear mucus out. And then in the peds population, there are a lot of congenital structural defects, and many times they'll do surgery early in life just to take this part of the lung out, because if you grow up with bronchiectatic lung looking like this, you're going to have pneumonia all the time, and that's bad. Often see recurrent pneumonia, especially staph and pseudomonas in patients with bronchiectasis. Mycobacterial infection is common, and also diseases that can lead to bronchiectasis, like allergic bronchopulmonary aspergillosis, vasculitis, and then if you have something extrinsic going on, tumor mass or foreign body that keeps a certain airway from clearing mucus, you can develop bronchiectasis in that airway. And finally, recurrent aspiration is a pretty common phenotype. And that's just some more sputum pictures for you because I like them.
And then the boards, they love the question of someone young with bronchiectasis, and you should order immunoglobulin panel on them because they have deficiency in one of the immunoglobulins.
And this is the most common, by the name, common variole immunodeficiency. And these folks will have really pronounced sinus disease too on the test. That'll be a hallmark of it. And they'll want you to order that IgG panel. The answer is never refer to immunology. You are the immunologist. So the treatment for bronchiectasis is control of infection and really augmentation of mucus clearance. Chest physical therapy for patients with cystic fibrosis, hand or vest therapy, and this flutter valve here causes the mucus and smaller airways to break up and assist with expectoration with cough. Cystic fibrosis, briefly for you guys, because this is more a peds issue, but you'll see some cystic fibrosis folks, is a problem with the chloride channel in not only the airways, but all of the secretory, mucus epithelium in the body. And most common mutation is delta 5FO8, which is a trafficking defect. The ion channel never makes it. Some of these phenotypes that are less common now have medications that assist the protein to get to the wall of the cell or help the chaperone process so the protein folds normally. And there are many oral medications now that really manage cystic fibrosis to the point where people experience improvement in their obstructive lung disease and GI symptoms. They gain weight, they're able to exercise. CF does create a bronchiectasis phenotype in the lungs, but when you are thinking about a patient with cystic fibrosis, they very often have diabetes from pancreatic failure, and they often, and usually failure to thrive is the main way this is diagnosed in an infant, because the intestines are unable to absorb fat-soluble vitamins well. So it's really a systemic organ. There's variable genotype and phenotype with cystic fibrosis. Some have primarily lung disease. Occasionally you'll see some with primary GI disease, but most, especially that delta 5FO8 mutation, have all of it.
And for the cystic fibrosis, when you order the testing, it has to be done twice to confirm the diagnosis. That's also, they love it on the boards.
And really, this chloride sweat test is rarely done anymore. They just go right to the genotyping if you suspect it.
Because with the genotyping, do they need 2 mutations for it or something for the diagnostic criteria, or not really?
No.
Oh.
Yeah. you can get an intermediate phenotype if you have one delta 5 FO8 and one normal, or two of the not delta 5 FO8 mutations. So you do need one delta 5 FO8 to have an intermediate phenotype. Some patients are normal, though the penetrance varies quite a bit.
Okay.
But two of anything else to really get a diagnosis.
Yeah, because I know like for the initial chloride sweat test, if it's positive, you have to repeat again to confirm the diagnosis. If it's negative, one of them or twice, then you go to the genotype for the boards at least.
And really for CF in adults, the sinopulmonary and GI disease are the biggest concerns. They'll have poorly controlled diabetes due to malabsorption, gastric motility issues, and then have admissions with basically bronchiectasis exacerbations. Yep. And if you do happen to diagnose CF in a young adult that's an intermediate phenotype, you'll win an internal medicine prize, which is more clinic. And you should refer them not just to a pulmonologist, but a CF center, because they need a comprehensive nutritional, social work, medication plan, and then, lung transplantation referral is the endpoint for people with severe disease many times. But just keep this in mind that milder phenotypes can masquerade as asthma. And if you see bronchiectasis in somebody in their 30s that always has infections, there's sinus problems, maybe they, are diagnosed with IBS or something, think about CF, and, adding the genotype on doesn't hurt, and winning the internal medicine prize, clinic forever, it's a good one.
Because 18%, I had a question about this the other day, 18% of CF actually present in adulthood, diagnosed in adulthood. So always keep it in mind.
CF exacerbation, they have to step down over time in FEV1 because the disease is progressive, and pulmonary infection and worsening obstruction are the hallmarks of continuing CF disease. Oftentimes they need admission for IV antibiotics. They grow a lot of really creative drug-resistant bacteria that like to hang out. Burkholderia is the one that shows up in patients with very severe disease, and that's actually a contraindication of transplantation because it stays in the body and infects the new lungs.
Because they start with Staph aureus, then Pseudomonas, and then Burkholderia.
Then Burkholderia, yeah. Novel therapies. And so summary for this part, bronchiectasis, obviously I gave you a very wide differential for bronchiectasis, and think about immunodeficiency syndromes. And really the treatment for it is airway clearance, mechanical airway clearance to help prevent infections. Know about CF, especially you may see it in adults. And the mainstay of therapy for bronchiectasis and CF is mucus clearance and antibiotics. Any questions on any of that? No one fell asleep this time. The last lecture I had a couple sleepers, and I know that's brutal. PFTs are not not terribly
especially when you go into the laws and how you calculate that.
Got to torture.
It happens
people.
every year.
Every year, yeah. Got a few sleepers. Yeah. All right. Well, thanks, guys. I'll see you. I think in a month or so is the next lecture in this series.
Awesome.